Yeah, no, look, as Doug said, I mean, when we decided to, quote, go global about 5 years ago, it was frankly in large part due to a lot of the framework that Paul, as an individual, but also Paul in working with Partners in Health, gave a framework for us as one other NGO to embark on our global work. And that's a hard thing to define from Austin, Texas. It's something that I've talked about with a lot of folks here in the room, with Steve and others, sort of how do you do that from here in Austin, how do you do global work? But Paul has helped, I think, be a great guide to us as one organization. As we just talked about earlier this morning, partnering is the key to the future of effective change in particular. And we're really, really lucky to have Paul take the time this morning, and we appreciate everything that, not only the time you're taking today, but all the work that you are doing globally. So thanks, and take your tie off. Come on.
Well, I didn't wear this for you guys. I wore this because I'm going to the University of Texas, Austin. How much time do we have?
You got about 35 minutes, right? Is that right, Emily?
Yeah.
Really? That's it?
Hey, it's up to you. If you guys want to change it, we'll hang out.
All right. Not even 45?
We have to leave at 4:15.
Do I have to turn around and look at the clock now? My colleague Emily Bonson, my taskmaster, who actually worked at Dana-Farber before she joined Partners in Health some years ago, and took a master's in public health, and has been. We've been working together for many years, and when I came in this morning and someone said, "Well, I'm from development. I do development." One of the LIVESTRONG folks. I said, "We're all supposed to be doing development, everybody," and that's the doctors, nurses. That's how we feel, because we're in essence, Partners in Health we're supplicants. We're saying, hey, we better have a strategy for people who are facing both poverty and disease, and that strategy has to involve the transfer of resources, which may be medications, diagnostics, obviously the money that you need to build systems. It may be people who have something that is needed in order to deliver care, but that transfer is really, in a way, what it is Partners in Health does, is moves staff and stuff to people who really need it to stay healthy and avoid illness, or to get over illness, or to not lose everything when they become ill, which is, I won't go into any economics or any of that stuff, because I don't know much about economics, but I assume most of you know that in pretty much every country studied, catastrophic illness is the leading cause of tipping from poverty into destitution. So the impact of serious illness, and cancer being accounting for more of a burden of disease than AIDS, tuberculosis, and malaria probably combined. This is a major problem for any group that's focused on healthcare delivery to poor people. So our partnership with LIVESTRONG, and I'll just go over update you a little bit. Our partnership with LIVESTRONG has a lot more significance than would be evident if you just looked at these resource flows, which are critically important to programs. You support a lot of programs that we implement along with our partners in the field. But the importance of these efforts is really potentially vast. That would depend on how much LIVESTRONG and Partners in Health and our other partner organizations here in the part of the world people talk about is the first world, how much we elevate it together. That's the limit on I think the potential of this endeavor. Now I've just said first world. You already can guess that I don't believe in that at all, that there are 1, 2, 3 worlds. It's all one world. And so for LIVESTRONG to go global, to me there was no way around that. And there's a lot of reasons not to try and remain bound by any kind of parochialism of geography or administration. It's a big, scary world out there in terms of the burden of disease, but a group like yours really had to go global, and we still believe that, and we hope that everybody in the leadership team, the employees, staff, board, everybody feels good about this part of the work. Now I'm just going to give some examples. So you already know these. We don't have a lot of time, but one of the things I think you will have to do is to make it clearer that this is just a ridiculous notion that cancer is a disease of rich people, and malaria is a disease of poor people. unfortunately, malaria is a disease of poor people, and so is cancer, and on it goes. The burden of disease, in what we used to call third world or resource poor settings, whatever the latest term is, the burden of disease is huge, and so it's also the majority of the burden of disease globally. If you want to use again the idea of low and middle income countries, that's where it's happening. So having partners who just acknowledge this and make it central to their work and their public voice, as Livestrong has done, is very important to those of us who are obliged by our proximity to such suffering to be engaged in it. In other words, if we're working in Rwanda, in a rural area, or in Haiti, where I'm headed back to from here, we're going to see lots of cancer. What we're not going to see are oncologists, oncology nurses, the medications and diagnostics we need, and the resources we need to help them respond. And what we've tried to do at Partners in Health is say, can we build a new system, a delivery system, that may not have all these bells and whistles, which would be good to have, but which can nonetheless deliver good, high-value cancer prevention and care and integrate it? And the answer to that now we know is yes, we can. And this is just some examples. Now, I just want to go back to your own wonderful writings on this that I just looked at last night and this morning. And I want to say a few words about stigma and how you could make this clearer in your work. This is not a patient with a malignancy. This is a patient of mine from Haiti who has, and I'm sure you can guess, maybe you've even seen this picture before, because these get circulated around with the patient's blessings. This is a 26-year-old who had AIDS, tuberculosis, and inanition, meaning malnutrition and wasting. That's a before and after. That's the same guy. And, this is the, people talk about stigma around any illness. A lot of it has to do with the fact that if there's no way to diagnose and take care of someone, and this is not even a curable illness in the best of settings, of course there's stigma. And it says here, you said, we learn that people view cancer as a death sentence. Well, again, without a delivery platform in places that could reach people living in poverty and having cancer, it is a death sentence. So it's not actually an error to stigmatize a malignancy or any other pathology that is inevitably fatal without treatment. That's not an error at all. It's only an error if you can put in place the delivery platforms to take care of the patient. So that's something I think also that Livestrong can make really clearer. You may understand it, but a lot of people do not understand that stigma as barrier is also related to barrier to diagnosis and proper care of an illness. And so, the amount of energy we can invest in having, for example, public service announcements. Imagine going to rural Rwanda just even 3 years ago and saying, there's no reason to have stigma on cancer, can be treated. That would have been a lie, because there was no cancer center treating poor people in Rwanda, or even non-poor people. So that's sophisticated linking of the new technologies that we do have for diagnosis and care, and these delivery systems is really the center of our shared work. Now, I just want to go back to, I train in infectious disease, but that's not because I think infectious diseases are more important than non-communicable diseases. I just think they're cool and like to diagnose and treat them. But the similarity between these other difficult to treat illnesses and cancer should strike you. That's my only point here. And also what happens when we're spanning these boundaries of really poverty and less poverty, or wealth and poverty. So tuberculosis is really basically the first infectious disease for which we have good therapy. Started in the mid-20th century, 40s, with a drug called streptomycin, which we still use. And one complication, as you know, of using antibiotics is drug resistance. And it's true of viruses, bacteria, mycobacteria, parasites, all of them. So the idea that this wasn't going to happen wasn't a really smart one. Right? Of course there's going to be drug-resistant TB, and then multi-drug resistant TB, and then extensively drug-resistant TB. These are all terms that we've cooked up in the TB world, XDR-TB, MDR-TB, TDRT, TDR-TB. And I said to a friend of mine, what is TDR again? And he said, totally drug resistant. I said, that sounds like my teenage daughter. Totally. So the problem here is that whenever it becomes difficult to treat something, the first things that happens for poor people is their suffering is declared untreatable. So again, this is, I'm just showing you dates around pretty important public pronouncements, which are, going to happen. This will be my argument. Of course, I'm going to show you that it's exactly what's happening. This is going to happen every time we move a pathology into the now treatable category in the rich world, in the world that we live in and are happy to live in. So it's always going to happen, would be my guess. And then, I've just been a little bit obsessed with some of the new things coming down the pike. For example, it's soon going to be possible to cure potentially a majority of people with chronic hepatitis C infection, which is pretty exciting, right? The point is, if you don't have a delivery platform, you're going to be hearing the same things that you already hear them, that it's not a curable disease for people affected by both the pathology and great poverty. And so we spend a lot of our time not trying to prove these statements wrong, but trying to take care of people who did have this particular disease, for which there are so-called second-line drugs. You've heard the term and used to apply to cancer. By the way, the terms that we use in infectious disease, nerdy language, to describe tuberculosis care and AIDS care, do you know what the term is? Combination chemotherapy. That term doesn't come from cancer care, it comes from infectious disease care. Because that's still the term we use in my field to describe multi-drug regimens for chronic infections like AIDS and tuberculosis. And so again, this idea that it's somehow radically different, it's communicable and non-communicable diseases, is really not true. Now, I'm not going to spend a lot of time. Sure enough, very shortly thereafter, as expected, this is about 4 or 5 years after the development of effective suppressive therapy for AIDS in places like Boston or Austin or in the United States cities, where I was in training at the time in the mid-90s in infectious disease. So it was the infectious disease fellows and trainees who were taking care of these patients, and within 1 year, the hospitals in Boston pretty much cleared out because people got up and went home, and that was a very exciting thing to see. Now, I happen to have been going already for 10 years back and forth between Harvard and Haiti, so I knew what was going to happen in Haiti. I just had to ask myself, how long before people in Haiti hear about these new treatments and ask me about it? And the answer was about 5 minutes after I got off the plane, after it was announced at a scientific congress in Vancouver. It wasn't even, it wasn't months later. So this always happens, and this happens all the time with cancer. You're sitting in a place in rural Africa or urban Africa or anywhere, and patients come and their families bring them, and then they say, well, is this treatable? And what do we say? We can't say, no, it's not treatable for you, which is, again, what some public health people think this way. We have to say, well, we're going to try and figure out how to bring more people into this era of modernity and cancer care, and of course prevention too. Now, I'm going to just say this is just from a few years ago. I actually prepared these for the Dublin conference that I went to. What year was that?
2009.
So that was already 4 years ago. We've come a long way. At that meeting, by the way, a number of people came up to me saying, really? Cancer is treatable in rural Africa? This was after my presentation, by the way, after I've spent half an hour saying, oh, look at how we can treat cancer. That was afterwards they said that. So this is, it's difficult to change because you can't change the ideas without having some focus on delivery of services as well. And the ideas they're not really incorrect. If you read these and pick them apart, I think what I've said to my students is when you read something like this, or you hear someone say it, you can almost always tell if they're, and I said this in Dublin, if they're saying these things to start a conversation about cancer care in developing countries or to stop it. Pretty much tell. And what we were trying to do and have done together is to start that conversation, which again in 4 years is I think many of you will agree we're in Dublin. It's in a different place. Now, I don't have to spend a lot of time on patient stories, but I just want to go into three specific, not patients, but their dilemmas. I, of course, know the patients as well. Now, one thing that is worth everybody in this room knowing about is when you get a readily deliverable intervention for cure or care, you should never forget that care is important too, whether or not it leads to cure. It should immediately come to mind as a potential for ready transfer into a so-called resource-poor setting. Places like rural Haiti, where we'll be this weekend. We're heading there from here, or Rwanda, Malawi, Lesotho. When you see this, you guys should be saying, "Oh, really? Is it that complicated to deliver an oral agent?" And mothers all over the world do that for their children, right? And community health workers. So I'm not saying it's that easy, but this particular drug was very helpful to us to save a lot of patients, but also to say, we shouldn't keep saying that this is not doable in resource-poor settings. But then there are more complicated cases. This girl is on your video, which is a lovely video, by the way. Who worked on that here? Anybody? We really love it, and I hope everybody's seen it. Yes. So I was on call the night this girl came in with her father, and that's always the story, right? Their family's been dragging them all over creation to get care, and I never did even have the time to sit down and ask her father. First of all, I had to work through a translator. This is in rural Rwanda some years ago, but all the places that he'd been. I heard part of the story. And then, much later, as some of you know, she came to the opening of our cancer center in northern Rwanda and gave a really good talk about this. I don't know if anybody filmed it. It was really great. She talked to her father, I think, also spoke about how he'd gone all over. That's always the story. And that's, by the way, back to the point about the leading cause of destitution among poor people is catastrophic illness. Imagine for poor people the expense of just moving around a whole country like this. And I was listening to a student of mine at Harvard, or a student actually not of mine, but of a colleague of mine, talking about cancer care in Vietnam, and just looking at that long country, and they have only 4 cancer centers, and the stories that patients told about having to get from their hometown to one of these cities. It's just there's so many nightmares that people face in terms of logistic barriers to good delivery. But this is she did very well, as you know, if you saw the film. But this is not like taking Gleevec. This is a complicated intervention that involves surgery and chemo, and again, but it was delivered without we had no oncologist on site, right? In Rwanda, there are none, and we did that with the help through partnerships. Just like LiveStrong is about partnerships, that's how you make this work go forward. And what is it? No one does it alone. How do you say it on your slogan? Something like that. Totally true. In any case, and then there are things that are really complicated to do, but are still worth trying. This, by the way, I can leave this here. I won't go into detail. It involves again this is what LiveStrong is supporting, and this is very resource intensive, right? Because the medications, for example, DFCI is Dana-Farber. The medications, their price is not determined by demand. You all understand that, right? Most of these medications are not like Gleevec, they're long off patent. But there's no demand for them because it's mostly poor people who have the disease, and without some system between the poor and the manufacturers and dispersers of these agents, there's no demand. So be very suspicious when you hear that there's no demand. There's no demand because people, we're not doing our jobs. Because if we connect poor people with a lot of burden of disease to the rest of the world, which is actually part of one world, did I say that? It's totally one world. There's going to be a lot of demand. So then, how it works, the setup, obviously it relies on modern information technology platforms, the ability to communicate between places like northern Rwanda and Boston through the internet. And then we have focused our provider mix on what we have at hand, a lot of nurses, who many would, anybody who's survived cancer knows that the nurses are your friends, right? They're the ones you really have contact with. but also community health workers, physicians, including surgeons when they're needed. We've been describing this more and more in the medical literature, but I know you're aware of it. And then I just wanted to say, but there are a lot of cases where you really can't do a bone marrow transplant in maybe in South Africa. I assume they do everything in South Africa, and it's not because the climate is suddenly different. It's because it's rich people and a modern medical infrastructure in that part of that country in Africa. But there's plenty of need for new technologies that we really haven't been able to develop in settings like that, and I don't think that's going to happen for a while, right? BMT is much improved from when I was training 20 years ago, but it's not something I think we're going to see around the corner. So sometimes we have patients who are going to do really well if they get part of their therapy where we can deliver it. We don't have XRT in Rwanda yet. We have to send patients to Uganda. That could be fixed in the short term, I think. Short term meaning in the next few years. Not by LiveStrong and PIH, but by our partners who could actually pull together the capacity for an XRT intervention. I think that's what we need in a lot of places that we work. But the bone marrow transplant, this is a transnational connection. And sometimes a reminder that we are all in one world. Now, you probably have heard plenty about this. This is your friend and mine, Larry Schulman, and your former president and mine, most of you, and the Minister of Health in Rwanda. This is just, it's kind of a partnership photo, right? That's why there is a cancer center in rural Rwanda. And Partners in Health built a hospital there, as you know. And some of you, how many of you, by the way, have been there? No? Well, you should, because it's really quite lovely. It's not saying we're suddenly going to have oncologists and oncology nurses, being trained in Rwanda. The error there is the word suddenly. It takes a long time. It's certainly worth doing since there's plenty of cancer and no oncologists. But in the interim, in the meantime, there's a lot we can do to provide good cancer care. And the details of this, some of you can easily find them, but they involve, again, these partnerships that cross national boundaries and are, in our view, going to drag up the quality of care, not just for cancer, but for any other complex disease. And again, this is linked to a system of community health workers and clinics where most patients would receive all of their follow-up if things go well. They don't have to come back to the hospital. And again, I told you that's what happened with AIDS. It's an ambulatory disease, chronic disease. It's what would happen with diabetes, major mental illness. It's what will happen with drug-resistant tuberculosis, which we hope in most cases we know it can mostly be cured. But this system is the right one to connect with, in my view. Just as a last picture, then opening it up for an exchange, we've also taken a big bet as Partners in Health, again, a partnership, after the earthquake in Haiti. By the way, we received strong support from LiveStrong, financial support, which again was out of your wheelhouse. That's my second young person term, totes and wheelhouse. But it was certainly, we feel, we're very grateful that you reached beyond what you usually do and supported Partners in Health. The nursing school, as you know, and the training facilities were destroyed in the earthquake. They were all concentrated in the city, which is where the earthquake occurred. And so we decided that with a lot of the resources that we received after the earthquake, that we would make a gamble and actually build a teaching hospital, the first teaching hospital in rural Haiti. And it is the first and only CAT scanner in rural Haiti. It's the only CAT scanner in there. There's a CAT scan, the only one in the entire public system. And that's another thing that we've shared with the leadership team here is the public system part is key. NGOs aren't working in opposition to public health authorities. They're working with them, or should be. And that's another area of discernment that I hope LiveStrong will use. I'm personally grateful you're supporting Partners Health, but you should be if we're serving the poor and helping the patient in Rwanda and Malawi and authorities build up their own capacity. So this is a big step forward, and it will be a big step forward for cancer care as well. And it's mostly focused on maternal and child health because That's the biggest burden of disease in that area. But it will be, and I invite, some of you have already been, but we're headed down there from here because we're going to, we're just going to push forward. We've already opened it. It's got a lot of, it's a state-of-the-art hospital, and Haiti's first one. And making it run is going to require a lot of partnerships that will be new for us as well. So I'll stop there and open it up for questions.
Good. Would you give us an update on Haiti since the earthquake and especially the cholera epidemic?
Yeah, well, the update that I would give, Eugene, is not all gloom and doom. It is not true that nothing has happened, and this is meant as a reminder. There's not many other places where you could build a 300-bed teaching hospital in less than 2 or 3 years, less than really in 2 years. So the idea that nothing can work, this has actually moved faster than a project would have, say, in Austin. And it's built to California earthquake standards. It's not shoddy construction. It's the largest solar-powered hospital in the developing world today. And that's what LiveStrong has been supporting there. So, but on with a more sober national assessment, this is probably the only large health infrastructure project that's been completed. And that's a shame. And the same for education. There have been very few. The private sector has more ability to move forward projects, and there have been some good, a major new hotel. But there's a lot way to go in public infrastructure. That, of course, segues into the cholera issue, because it's really public, not private infrastructure that's needed to protect a large public from waterborne disease. And it's going to be very difficult to control cholera, or eradicate it in any case, without long-term accompaniment-style support of the public sector as it tries to build water security. Haiti was the least water secure country in the world, probably, by some measures, before the earthquake. And in fact, people thinking that cholera is related to the earthquake, that's not what it's related to. It was, in fact, people in the earthquake zone had less cholera because they had more access to water from the humanitarian machinery. So there's a lot of ironies. What we've tried to do as Partners in Health is, again, what we just said around cancer. Okay, what tools are available that are new that could help our long-term approach to water security, which is building up water and sanitation? And the answer to that question for us was, well, there's a fairly new cholera vaccine, an oral vaccine, like Gleevec. And again, we ran into the same difficulties, a year of people saying, well, it's not cost effective. I was tempted to say, well, how do you know? How do you know how much it costs not to intervene? And the answer was that we didn't, because it's the largest cholera epidemic in the world today. And there was never any cholera there before. So we did our own pilot with the public authorities, high uptake, no adverse events. And so our argument there on cholera was the short term involves things like, chlorine tablets, et cetera, but also cholera vaccine as we're building up water and sanitation capacity. It's going to take many years, a huge amount of money, of course, not huge compared to stuff that gets wasted all the time in other countries, but it's going to take a huge amount of money compared to what's available now for water and sanitation. And so, overall, the recovery, the Haitian people are really, strong. I'm not going to say resilient, because that could be said, but you're not resilient if a building collapses on you or on your legs, and then you don't have access to care. It's not the right term. But there's a forward movement and upward movement, and so we're hoping that Haiti will not be the outlier in terms of health indices for this hemisphere in the coming decades. But it's going to be a lot of work. And again, NGOs have to learn how to support the public sector and to coordinate, as we're doing with LiveStrong, because it's too many NGOs doing too many things.
I'm curious to hear what organizations you're excited about that are addressing some of the challenges related to distribution, the rural nature around the world.
Yeah, I mean, I'm partial to the Clinton Foundation, especially what used to be called the Clinton HIV/AIDS Access Initiative, and now it's called the Clinton Health Access Initiative, which is a subtle and important shift, because it's a shift away from a vertical problem, which was desperately needed at the time. There were no, when they started CHI, I'm actually on the board, I'll say that not as a disclaimer, but I'm proudly on the board of CHI. There were no programs focusing on AIDS treatment. There were AIDS activists who were helping us to say, hey, we can't have this double standard. But so when CHI started focusing on a public sector policy around AIDS treatment, integrating AIDS treatment and care, they were pretty much there alone. And then they also focused on procurement that would drop drug prices. So that's one of the groups I'm excited. I'm going to ask Emily to chime in at will, but and then of course I'm very interested when NGOs connect to fill in the missing pieces of the platform, what I've called the delivery platform. You know, that could be, for example, do we really have to learn always how to take care of vehicles, motorcycles, jeeps, ambulances? Wouldn't it be great to have a group that only focus on that? Oh, there is Riders for Help, you know, and you know or do we really have to think about how to solarize? I mean, I got an email yesterday about electricity, you know, our relationship between the hospital and the public utility, electricity utility in Haiti. And, you know, frankly, I wish there were an NGO that said, hey, we'll take care of that part of the platform. Now, there was a group like that, and some of you may have known that we worked with a group called Solar Electric Light Fund to solarize all of our facilities. And, you know, we worked with them in Rwanda, Malawi, Lesotho, and we said, come to Haiti. That's where we really have a need to get off, you know, diesel. And our chief implementer was killed in the earthquake, an American who was down there. So there are lots of setbacks like that, but that's the thing I look for in people doing innovative work, is they're willing to take the long road of accompaniment and help build up local capacity. I also, I mentioned already the AIDS activists. Treatment Action Group TAG, the amount of information they know about new therapeutics for HIV, tuberculosis, and HCV far surpasses any infectious disease expert I know. And they're, you know, they're working with other groups to try and build this delivery platform. So I could go on, but it's really the criteria by which I judge the NGO actors. They ought to be nimble, ought to be quick, ought to be able to bring in new technologies when needed, ought to be able to, you know, shift things around, like we were just talking about the LiveStrong PIH work in Haiti. You know, it's going to be very unlike some established arena where you can plot everything out and agree on the metrics and then, you know, plan your sport around some obvious and easily attainable or not so easily attainable goals. That's not how it is when you're starting something new. So the nimbleness and, you know, sort of egalitarian laterality, I don't know what else to call it, is important too. Yes, please.
In speaking about stigma and culture and platform delivery, basically you're telling us that we shouldn't really go into somewhere if there's not, and to try to address stigma unless there's platforms for delivery. Is that correct? And then could I ask you to think a little bit more about the role that LiveStrong in particular might play in affecting or facilitating culture change in terms of stigma? Is there something else we should be doing? Could you speak a little bit more?
Well, there are times when I'd be tempted to put it that strongly, as you did. You know, to say, if you're not going to be involved in the, you know, in the delivery piece, please don't, you know, come and talk about stigma. But what I'm really saying is a little bit less emphatic. Well, not less emphatic, but it's a little bit different. It's please find partners who are addressing the number one cause of stigma, which is the fact that it is a fatal disease for everybody who doesn't have care. And it, fill in the blank. I just said it was the same thing around. And you know, MDR-TB is airborne. You know, it's even worse because not only are you not getting treatment because you have a difficult to treat form of the disease, you're spreading it to your family, coworkers, etc. So again, if I could say it this way, a group like LiveStrong, and again, this may sound self-serving, but I'm a volunteer for Partners in Health too. It's not like, you know, it's not my day job. You know, I'm volunteering because I believe in the cause, and that's why we started it. What we would say is, it's really good that LiveStrong, given its larger-than-life presence around survivorship and stigma, thinks it's important to have in these areas where there's no delivery for poor people, thinks to have partners who are doing the work. And so I think the message around stigma reduction, and again, I should fess up here that in addition to being an infectious disease doctor, I'm an anthropologist, and a card-carrying, PhD-holding anthropologist. And I've just seen how the message can get distorted. And this is the main way it gets distorted. Stigma is a barrier to care and good outcomes. And stigma is also a reflection of barriers to care and good outcomes. And the best way to lessen stigma is, I'm not talking just about cancer, is to make sure that people do not die unattended of a lethal, painful, and wasting disease, or a set of them in the case of cancer. So I think it's worth, us getting that out there together. That it's not what's happening in patients' minds that's determining access to care. And if it isn't what's people's minds, it's those who control vast resources, not poor who have cancer. They are not the determinants of whether or not there's a delivery platform for cancer or AIDS or tuberculosis. It's powerful people who need to, change their minds. And I think LiveStrong will have a really good role there too, because LiveStrong can also reach out to legislators, and I know that's what has happened in Texas. And that's a huge return on your advocacy and activism. I think around stigma, we can refine those messages very carefully and say it's never a good idea to talk about stigma through campaigns that are completely divorced from any meaningful delivery efforts. And that's what we try to say around AIDS, drug-resistant TB, you name it, whatever latest rebuke to hope there might be. And I think it's really important to be the lead agency on this, because you're the lead group, because you're the lead group. People are looking up to you to have really clear messages about anything related to malaria. Is that helpful at all?
Very much so.
And I would personally happily be involved in that, as a card-carrying anthropologist. I know. I'm just sticking up for myself, folks,
I'm sorry to take more airtime, but it's connected here because I look back at the 80s around AIDS and stigma, and part of what came around is because my friends with AIDS who were dying didn't do so quietly.
Yeah.
And it's around the issue of survivorship and how you're empowering people with the disease to demand services. I think that was a critical component of the success of AIDS treatment.
Absolutely. And the other point that I'd like to underline is that led to what? That led to development of therapeutics. And even with a poor quality therapy delivery platform, as we have in the United States, we don't have a high quality delivery platform. We have high quality tertiary care medicine and great research. We don't have a great delivery system that's egalitarian and readily accessible to everybody. We still had a huge decline in mortality. So the changing view of AIDS as a lethal disease happened because it became a chronic manageable disease, and that was because of treatment platforms, which of course don't reach everybody in the United States. And there are real problems around that too. I would just say that the second great victory is that many of the AIDS activists that we work with said, well, we care about the rest of the world too. And so they have again been our biggest allies in these so-called difficult to treat forms of HIV, TB, and hepatitis C. And it's an important lesson. Is once you're able to be alive, then you can be an even more powerful advocate because you're not gone, and more powerful voice for equity in healthcare.
We have time for 2 more questions.
Thank you. I was like, Morgan, back here. Dr. Farmer, so my question is, so Partners in Health is proving that it's possible to deliver comprehensive cancer care, in the developing world. So what do you, in your mind, what's the strategy or the next step moving forward to start changing hearts and minds and to start to see the cultural and the institutional shift sort of in the international policymaker world? So what, how do we take the results where we know that it's working, we know it can be done, and shift that into sort of large scale political will and then awareness and change?
Well, and that is in a very way, not the $1 million question, but the $1 billion question, right? And one thing I'd like to remind everybody is, I think you probably already know, is that shift can happen abruptly. I mean, PEPFAR, President's Emergency Plan for AIDS, it came out of it came out of commitment, but in the due diligence they were seeking came from a very small group of physicians who were saying, well, don't say it's impossible, we're doing it in Haiti, or we're doing it in Rwanda. And then suddenly, the whole conversation changes around, cost-effectiveness, feasibility, because once you've got the resources, then what happens is you start being able to treat patients and learn as you're doing it. Again, this is the feedback loop that, we hope that Partners in Health, which is connected to academic medical centers, hence the tie. My gig here is with UT. We hope that we're going to learn lessons as we're doing it, right? Delivery lessons. And again, I think anthropologists have a lot to add because, and other sort of re-socializing disciplines like that also have a lot to add beyond what epidemiologists and physicians would have. I'm just saying that can happen suddenly. It's good change. It depends on really reaching out to people who control those levers, and you do that. So I think one of the things that's different about Livestrong's advocacy is it isn't based on a restrained set of what are the most cost-effective interventions. You don't know because you can't really assess what something costs. I gave the example of how much does it cost to have a runaway cholera epidemic, the largest one in the world? A lot. We don't know how much. How much does it cost to have the cervical cancer bill, take it, or have as many women lost to cervical cancer as before the vaccine? A lot. It would erode confidence in the vaccine and other public health measures significantly if it doesn't get delivered. So, and effectiveness too. Effectiveness changes. And that's where another place where Livestrong is important, because just when you get something set up, after years of fighting to get it set up into a public sector, then you say, oops, there are new technologies, new, better drugs. Now, and that's hard on the people who are the implementers, because it shouldn't be. They should say, thank God we have new drugs or new diagnostics. But it actually requires a lot of work around logistics, supply chain, etc. So having you guys push this forward rather than be pulled forward is a big part of it. And again, back to where do you intervene? Well, if you work in partnership, which Livestrong does, you intervene on all the following levels. You intervene at the level of a community with community health workers. That's through your partners. At a district, at a clinic, at a district hospital, at a place like Butaro or Mirbalais, you intervene at the level of your home area where you live. Austin, Texas. You intervene with local and state legislatures. You intervene at the federal level. You intervene at a global level by working with regulatory standard-setting bodies like the World Health Organization. So I think, unfortunately for you and for us too, we have to try and intervene at all those levels. Fortunately for us, we do so through partnership, and and it's doable. And I don't know if I really answered the question, but if Livestrong defines its effort as breaking down old ideas that cancer is fatal for everybody, that cancer care is fatal for poor people living in places where there's no delivery, and we have to work with partners to change that. That we can't, we have to have these endless debates about prevention versus care, or AIDS investments versus maternal and child health. Those are the debates that really damage our work in global health equity. They're the ones that slow everything down. Getting beyond that, it would be, I'd expect nothing less from Livestrong to help raise up the quality of the, or again, like as we were saying, stigma as barrier but not product of the fact that people don't have access to care. That kind of work is critical. It would be a very different problem and a much smaller one if we can actually have the delivery platforms and reach out to places all over the world that could use the preventives but also the diagnostics and treatment. So, and there are others where we've got a long way to go. I mean, I was reading on the way here on the plane last night about islet cell transplants for pancreatic cancer. I don't know anything about it, but I think we should be applauding innovation whenever it occurs and whomever it could benefit, and not be, Luddite against that, and then be asking as quickly as we can, okay, when an intervention is effective, and how do we, that's the E word we always want, it's effective, and how do we help think of a delivery platform and bringing down costs. It's a lot of work, but it's the kind of thing that's your sweet space. You said 2 more. Don't try to shut me off.
Hey, it's your time, man. One more quick question. You got about 1 minute.
How about 2 and I'll synthesize them in 1 minute.
Absolutely.
Last month, the foundation testified before Congress to talk about health system strengthening and addressing NCDs. You noted the success of PEPFAR, and a lot of our message is around leveraging the PEPFAR platform to address NCDs. What advice do you have to us in our communication with members of Congress to get them to understand that the success stories from PEPFAR can be leveraged to encompass more of the NCD group?
And, related, totally off topic?
Not related to hers, but you brought up 2 words, community and volunteering.
Yeah.
And those are very important words here at LiveStrong. And I was wondering, does Partners in Health offer a short-term volunteer program that people like us could?
Yeah, let me just, I can dispense with that in a short amount of time. The answer is yes, and Emily and I can leave contact info. The short answer is yes. And what we want to do is have more volunteers from the first world and reserve more capital for job creation for community health workers, and which is tough. If I had to choose one thing, I would say the main thing not to do is ever to attack the AIDS funding or to say there's too much going to AIDS. That's ridiculous, right? There is all diseases of poverty are neglected diseases of poverty, right? And that has been the refrain in a lot of the advocacy work I've heard, and I've said I don't think that's a good way for the NCD movement to go forward by, arguing that other pathologies are getting too much attention. This is dead wrong, and it must be kind of in human nature because it happens all the time. And so I would say we have to be vigilant and about that, and never do that, and especially not when we're fighting for health equity, because we've got a long way to go before there's enough attention paid to AIDS or any other disease that I can think of that affects primarily poor people. Another is that this Dullsville arena of health system strengthening. I wish it was exciting and sexy, but who wakes up at night and says, "Let's make a poster for health system strengthening"? Some of my students made a sign at a demonstration. I actually did the demonstration. It says they were chanting, "What do we want?" And the answer was evidence-based medicine. When do we want it now? So it's hard to sell health system strengthening, but that is maybe the appropriate venue in which to do it. You capture people's vertical enthusiasms around AIDS, cancer, things that have affected them directly, right? Or that they know the story, the narrative's clear. Here's someone sick with a disease for which we now have therapies. How are we going to get them to people? But in the end, what you're trying to do is take those vertical enthusiasm and make them serve the goal of protecting people from health risks in general. And I think it's doable, and I think you guys are on the right track. Stick with cancer in the sense of this is your, the area where LiveStrong has its brand, as they say in business. But you're already focused on health system strengthening by helping groups that are trying to do that, and local capacity building. Is this helpful?
Paul, thank you, and thanks for